All right. Well, it looks like we have enough people kind of jumping on. So we have another case series today, and I have the pleasure of introducing our speaker, which is going to be Dr. Guy Nicolette. He is a associate professor at the UT Health San Antonio and serves as the current director of sports medicine for the San Antonio Spurs. Before this, he did his residency in sports medicine fellowship at the University of Oklahoma Health Sciences Center. And then following this, he became a team physician and eventually fellowship director at the University of Florida until 2019. And during this time, he had extensive training of fellows, over 30 of these, in primary care, sports medicine, sports ultrasound, as well as orthobiologics. And many of these fellows have now gone on to cover a wide range of high school, collegiate, Olympic, and professional teams. And then following this, from 2019 to 2023, he was the executive director and athletics team physician at the University of California, Berkeley Health Center. And he has been an active member of the AMSSM and has published on tendinopathy, foot and ankle disorders, as well as a variety of sports medicine related topics. And today he's going to be providing us a presentation on a Morel-Lavallée lesion.
Thank you so much for that intro. I really, when you mentioned the fellows, I think that's the thing that I'm probably most proud of is the fellowship and seeing fellows go do things that they love to do. I used to ask everybody, okay, you're here, no messing around. What do you really want to do with your life? And to see fellows achieve that is incredible. I also used this platform extensively, probably not only augmented but replaced some of my teaching in ultrasound. So it became a wonderful crutch in a lot of ways. Well, as you said, this is about the Morel-Lavallée lesion. Just one quick slide on the background because I think that stuff is fascinating. So it was actually not two. I used to think it was two doctors or two people that had kind of described this at the same time, but it's one person, a French physician, and I'm probably pronouncing it wrong. But Morel-Lavallée published way back in the day. I think the important background part of this, why is this an issue, is that these injuries can cause a pretty significant cosmetic deformity, and it comes from the tissue necrosis if left untreated. And I think everybody knows, certainly the board answer around the Morel-Lavallée is that this is a shear force type of injury, and they often say, somewhere in the description, kind of closed degloving type of injury. So here's our case. And I was laughing a little bit before everybody came on because this case is 15 years old or so. And that will become evident as you see some of the images. But it was, and I had a run of them. I had about 3 or 4, and we actually ended up publishing a case series. But this one was probably the most classic. So I'll read it for those that can't see the screen. 22-year-old female presents more than a week after having a large tractor tire fall on my right medial thigh during advanced workout at the gym. I'm trying not to use proprietary terms, but I think we all know these advanced workouts and their name and what happens when people are lifting tractor tires and such. Anyway, she resumed her workout after the injury, but the next morning she had extensive ecchymosis and swelling of the distal medial right thigh, no hip, no knee pain. Advil helped a little bit, and she tried to keep going, but she just was unable to ambulate normally because of swelling and pain, and certainly didn't have any neurologic complaint. On exam, she had a slight limp. There was a substantial ecchymosis noted on the right medial thigh superior to this area of abrasion, and from the outside, it measured about 4 centimeters by 2.5 centimeters. There was soft tissue swelling in the medial thigh, and she was moderately tender. had full range of motion and a normal ligamentous exam, and their strength was intact. Okay, so here, that's the patient. And there really is no, at least to my knowledge, and certainly not at the time, there was no defined protocol for these soft tissue injuries. And because it was obvious that this was going to be, the differential was going to include more soft tissue injuries than harder tissue injuries, and certainly the joints didn't seem to be involved. We really had to think about how to do a thorough, comprehensive exam. And so really, some people, myself included, really focus on bony landmarks to start every evaluation. I'll say that I've moved away a little bit from that in some of the hamstring and other soft tissue injuries that I do. But more often than not, we're starting with a bony landmark, and then of course understanding your anatomy is critical. So in cartoon form or graphic form, here is the outline that I believe helps you in these anterior thigh soft tissue injuries, and to try to catch most of the soft tissue planes and catch some of the other structures that could be involved and make up the differential. You see them on your screen there. The other thing that I think is helpful, or was helpful for me back then, is I often will go back to an anatomy book. And even though I think I know anatomy really well, there are times when I really need to reconfigure the 3D anatomy in my head, and this is no exception. I really like this picture as well because it hints to the kind of interdigitation or the overlap, particularly in the vastus intermedius, the medialis and lateralis. They at times cross over without great tissue, fascial planes, and can be confusing in your ultrasonographic scanning. So to start with that protocol, or start with that thought process in mind, start at a landmark. Again, most of the time that's bony, and so the ASIS and the AIIS serve as great bony landmarks to start the ultrasound exam. This was 30 centimeters away from where she was having a problem, or 20 centimeters away from where she was having the problem, but nonetheless, starting there is important. I'm also going to acknowledge that this is not the protocol. Exam images are not the patient, and I'll explain here in a bit. So this was obviously long axis for ASIS and AAIS or AIIS, and then switching to an axial plane for the majority of the exam is probably where most people are going to go. So there's the ASIS in short axis. And so now we're just going to move down to the next one and follow these red boxes. So you can see here that we're just distal to the ASIS, and now distal to the AIIS, and see the rectus femoris RF, sartorius, and tension fasciae lata. So left side of the screen is medial. And just working our way slightly down, the rectus femoris starts to enlarge. We still see part of the sartorius. And now we're headed medially. Again, not just because the patient had more medial sided symptoms, but there's quite a few tissue planes as the sartorius is coming down. So, and this catches one of the areas of differential. So again, sartorius at the top, we're starting to see the adductors because we've moved so medial. So there's the adductor longus and magnus. And then in the middle, your neurovascular kind of structures, the saphenous nerve, femoral artery, and vein. And then you can get a hint that vastus intermedius, and that's labeled VM, but it would be vastus intermedius is right there. And just for proof, which I try to do every time, I'll be honest, there are times that I forget, but I do try to take an image of the vascular structure, particularly with Doppler or color flow, to prove that that's what we're looking at. So as we are sliding down distally, I then try to anchor using the rectus femoris as kind of home base, I suppose. It's immediately identifiable. In 99% of people, you will see the tendon, the intermuscular tendon, as it's writing right here. I think I have that highlighted here. This is a different patient, but just to highlight that in everyone, you're going to see this tendon, intermuscular tendon, pretty much most of the length of the rectus femoris as you go distally. And then here is side by side. And if you had trouble seeing it, that's what we're talking about. So this is a good way for me to find home base, to anchor, that I know that I'm at the rectus if I'm seeing that. Again, in all of these studies, what we would be looking for, particularly in a patient like this, is the fascial plane. So the plane around the rectus, the fascial plane that can, is separating the rectus from the sartorius, from the vastus medialis, from the intermedius. So in all of these protocol images, there's no abnormality. Now we're continuing to work down medially, and I like this. So this was the area of the patient's swelling, and I like this image. I like this spot because you can see multiple tissue planes between the rectus femoris, the VMO, the vastus intermedialis. We're using a deep enough setting to have the femur as the bony anchor, and you can really get a sense of 3 different muscles and their tissue planes. And then on the right, really sliding even more medially to catch the VMO, because in the differential, not only does could this be a neurovascular problem? It's unlikely to be, but it could also be an intermuscular hematoma, and that's really, frankly, the 2 biggest elements on your differential for that kind of patient would be, with soft tissue swelling that was traumatic, would be a hematoma or this Morel-Lavallée, some sort of closed degloving type of injury. And then last but not least, trying to get as much of the fascial planes and musculature in the distal thigh in frame, so that you can really get a sense of any fascial plane abnormalities, swelling, or certainly intermuscular hematoma or other abnormality, rectus femoris, vastus lateralis, VMO, and VI, all in one image. Again, this is going to be pretty distal. As we move more distal, continuing to move distal, again, you see the rectus femoris starting to go into the quadriceps tendon. And then last but not least, and again, this was not the patient. In today's world, it is really helpful for me, both for anterior thigh and posterior thigh, to try to get an extended field of view image. I did this very curvilinear on purpose. I was trying to recreate really what the anatomy kind of looks like when you're faced with a 3-dimensional patient. But here on the medial side, of course, would be the VMO. Here's the rectus femoris in the middle, the vastus intermedius, right next to, you can see a small sliver of the femur there, and then the vastus lateralis. A different patient. So back to the case, and here is why none of my images are from that patient. This this case was in 2012, 2011. There was no extended field of view on the unit at the time, and so we had to manually stitch together images, and some of you will remember having to do this. But here was this fairly substantial fluid-filled abnormality with what I called kind of a cystic or amorphous piece of tissue inside of the fluid-filled mass. And so a fluid collection in the medial thigh measuring 8 by 4 by 1.5. So again, I didn't, it's difficult on the old units to measure the entire length of the mass. So there's no measurement here. I just had to stitch something together and somewhat approximate the measurement, but it was pretty close. So 8 by 4 by 1.5 centimeter mass. We suggested needle aspiration, but she really wanted to discuss with her parents. So we put a compressive wrap on and saw her back. So we went ahead and aspirated and got about 35 cc's out, 34 cc's out of serosanguinous fluid. So at that point, the fact that it's not fully sanguinous, the fact that it was between tissue planes, and I'll show you quickly here. So up here is actually sartorius, and down here on the lower left is VMO. So we were in mid-thigh, just at that location that the sartorius is curving to go meet, fully medial, but still lateral to the vastus medialis. I'm going to stop here and not read this report, but touch on the main points. So on these reports, and I follow a lot of Doug Hoffman's way of describing things, and certainly his formats that have become popular. But the indication was trauma to the right medial thigh. The positioning was supine with slight hip external rotation. For me, the positioning matters so that I can replicate the best I can on serial exams. Certainly the technical, this was a 12 megahertz linear array transducer. And then I tend to bullet point my findings, and that's just because of the way I think. Reading a long narrative paragraph, sometimes I lose some of the detail in that. And so I just tend to prefer bullet points, but obviously that's a stylistic choice. Again, since we started at the AIIS, in that particular patient, the bony contour appeared normal. I list the muscles that I scan, and I try to scan in long axis and short axis, particularly in multiple axes over the area of interest. I don't tend to, just time being what it is, I don't tend to scan long axis over the entire anterior thigh in this case. No muscle fiber or tendinous disruption was seen of the vastus medialis or rectus femoris, or in the region of maximal discomfort. And then this 8 centimeter hypoechoic fluid collection was seen in the fascial plane vastus medialis. Again, I don't tend to make a diagnosis in the findings. I separate it out to the impression, which to me matters. Again, a stylistic choice, but my impression, given the fluid collection in the fascial plane and the appearance of some likely, the early tissue that's likely not necrotic yet, but was a Morel-Lavallée lesion. So my impression was Morel-Lavallée lesion, right anterior medial thigh with an interlesional debris, and no significant muscle, belly, or tendinous disruption identified. Obviously, impression number 2 isn't a diagnosis, but I also like to remind myself or anybody else that's looking at the chart that we were thinking about at least the main aspects of the differential. Just quickly, and I'll end this presentation, that here was a during aspiration shot of this particular patient from the right medial thigh. Here is during late aspiration. You can start to see that even though I'm pretty far off screen, we've narrowed the size of the lesion, and now post aspiration, trying to get most of it on the screen. With an older unit, you can see that the size of the lesion has really decreased maximally. So since that was done, I usually add either an addendum or just include it as part of the report, the post aspiration, and I don't go through anything other than what I saw, post aspiration. If I had elimination of the lesion, or if there was residual, or what I got out of the aspiration. So 34 cc's of serous fluid aspiration. Just to finish the case for learning's sake, it took about 5 days. She had some reaccumulation. We aspirated again, got 21 cc's, 14 day, and we're reading the literature at this point, pretty, trying to figure out what other options we have, talc or doxycycline or whatever. But since the lesion was decreasing and she really didn't want to do anything other than aspiration, we continued to aspirate. And frankly, repeat aspirations worked, and that was part of our case. That was part of our learning from this case series, is that repeat aspirations for these Morel-Lavallée lesions often work very well. So she had a really good outcome with minimal to no cosmetic deformity, which is really the case we're looking for. I'll stop here, but again, thinking of Morel-Lavallée lesions really come in 2 categories. One is, at least in what I do, it's baseball players, softball players, basketball players with a really hard fall that tend to slide a lot on that surface, or this direct shearing blow, like in football, like in lifting tractor tires. So, Stephen, I think I'll stop there.
All right. Well, yeah, thank you so much, Guy, on the presentation for, this topic that a lot of us are gonna, start to be seeing here in the fall season. As you had mentioned, I think that this type of injury, you're gonna see it with contact sports, especially with football. And so I think this is kind of a really good, primer going into the season. A couple comments that I would make with the Morel-Lavallée lesions is, as you had mentioned in your kind of report and throughout the talk, the location of these can occur a wide variety of, regions, throughout the body. More often than not, it's going to be in the thigh, but just kind of like what you were doing, there isn't then a real set protocol for these, just because, they're kind of in no man's land. They're usually not happening at a joint. But the key still there is, going through methodically, like you were doing, as far as the anatomy, what muscle, tendons, bone are in this region, and going ahead and describing that, and making sure, as well too, with the ultrasound evaluation, that you're concurrently evaluating for any, injuries, whether it be a strain or intramuscular hematoma, as you had mentioned, that can occur, concurrently with the Morel-Lavallée lesion, just because obviously that may change, prognosis. for the patient, as well as treatment. And so that would be, one thing is, just be consistent, kind of as you had mentioned in the protocol, just describing what anatomy is in the area, especially just because these can happen in a variety of places. The other thing, I would say in your description that is kind of key and then classic for these Morel-Lavallée lesions is then going to be the location. So just remembering that when you're trying to figure out these versus like an intramuscular hematoma or other type of soft fluid collections, is that these are going to be then deep to the subcutaneous tissue, but then obviously superficial to the deep, muscular fascia beneath those. So that's kind of where these are occurring at. And then lastly, I would just say, these kind of, soft tissue, fluid collections, soft tissue masses, this can be one of those things that you don't see a lot of. And so I think it's helpful, at the beginning when you start to see these, is just being consistent kind of how you're describing them. And as you had mentioned, these are going to be fluid collections, but other things that you had kind of described in your report is going to be the shape of the fluid collection. Is it well circumscribed? Does it have a capsule? Is the fluid compressible? The appearance of the fluid, is it anechoic, hypoechoic? Is there, internal debris that are, mixed echogenicity? Does it have any, regular borders? And then, as well too, does it have any vascular, flow to the region as well too? So those are all things that I think are, important, that when you do see these fluid collections, just because then when you can kind of go through that set framework, it gets much easier to kind of come down to a set diagnosis with these type of fluid collections, especially, differential wise. So those are just some of the comments that I would have, but I'll go ahead and open it up for anyone else that has any questions or comments.
Yeah, this is Doug Hoffman, Guy. Very timely, as Stephen mentioned, as we get into the fall sports. From my perspective, this is where ultrasound shines. To have the ability to diagnose these quickly is important because potentially the outcome can be changed versus delayed diagnosis and treatment. And so a lot of times there's point of care ultrasound in the training room. And again, a quick diagnosis and a fairly easy diagnosis overall can make a difference. Some of the tough cases are the ones that have been delayed in diagnosis. So again, this is one of the areas that ultrasound really shines. For my protocol, I do a lateral hip protocol, but to be honest with you, if I'm not doing a complete exam, we're mostly doing limited exams and just confirming the presence of, a seroma, lateral hip seroma, and then go from there. But if I do a protocol, for me, this is a lateral hip protocol. I do want to highlight the fact that, extended field of view is an important image for measuring in all three planes, particularly if you're treating and you're following these patients. The measurements, I think, are important. The other subtle thing that I look for is capsular thickness. So you'll find that if you see these right away, there's not time to develop a capsule, so it's a split in the fat lobules, versus if you have a subacute or delayed onset in diagnosis, you're going to see a thickened capsule, which oftentimes is going to make treatment a little bit harder. And so that's one of the other subtle findings I look for is there a capsule that is formed yet or not? For me, the differential diagnosis is pretty straightforward, but the main differential would be a fat necrosis because both are typically trauma related. Obviously, fat necrosis can have a little bit of fluid, but the fluid is not going to be encapsulated. Fat necrosis tends to have mixed echogenicity and it's going to persist. So, it's good to know if there's fat necrosis versus a seroma because they do have different outcomes. I've also seen a few tumors in this area, or, before imaging, a lipoma can have a similar feel to it. It kind of feels squishy. I've seen fairly large one on the lateral hip. So don't assume that if you feel what you think is fluid, that it is a seroma. It could be a lipoma, or I've seen a couple other types of tumors as well. But for the main key ultrasound finding that you both mentioned for me is the presence of encapsulated fluid, and I just want to add compressible. All seromas should be compressible because it shouldn't be significantly thickened fluid. And so if you see a seroma confined or fluid confined to the subcutaneous tissue, it's compressible, then you have your diagnosis. You know, we're not getting too much into treatment, but it's this approach, and I find that serial aspirations, if you can get them acutely, can be quite successful. And so again, I am using extended field of views and measurements, as well as sort of monitoring the volume that I'm aspirating to know that these serial aspirations are successful versus spinning your wheels. So again, nice job, Guy, and a timely topic.
Thanks. And it's a great point about the soft tissue masses, that the ones that I've found that are quotes incidental, you know, they come after trauma, but it was there for a long time. It's just, it took the trauma to notice notice the abnormality. So that's great to keep on the differential.
Yeah, Doug, thank you so much. Yeah, I think that brings up a good point. I think where these Morel-Lavallée lesions, as you had mentioned, they're pretty easy to identify if you get to them early, right? But then the key is if they get later and later in the presentation, that's where the appearance of the fluid or the capsule, it does kind of start to become, you know, a broader differential for a soft tissue mass. But that's where now the advent and the benefit of ultrasound is that so many of these injuries we can catch, you know, very, very early on, that it can make it an easier diagnosis, be able to get quicker treatment, and really prevent these patients from needing a more extensive, you know, workup for a soft tissue mass, just because, you know, with the ultrasound, we're able to now so easily diagnose and treat these injuries.
The only thing I would add to that is that, you know, and I know I didn't, you know, because of the nature of this series, didn't focus on the treatment as much, but you know, if that patient had come to me 3 years before, when frankly I wasn't doing ultrasound and ultrasounds weren't widely available in every sports clinic, it would have taken more time for more workup, and all of those things that Doug and you have mentioned would, you know, we were risking that. So it's not only the delay to diagnosis, but it's the delay to treatment. We could have done that aspiration on visit 1. We didn't, because she wanted to talk to her parents, but the point being, it has revolutionized, I think, a lot of the treatment, even of hematomas. And I know that's not what we're talking about today, but you know, we used to wait those out, or, you know, get some advanced imaging at times, and now really an ultrasound and at times a needle, and I believe the patients are way better off because of the lack of delay in treatment.
All right. Well, unless anyone else has any other questions or comments, I don't see anything in the chat. So I think that will kind of complete today's presentation. So once again, thank you very much, Guy. And we'll go ahead and meet again in 2 weeks. And at that time, we're going to have a case going over another fluid collection, which is going to be pre-patellar bursitis. So we'll see everyone again in 2 weeks. Thank you very much.